I'm Ben Bridgewater. I'm a consultant cardiac surgeon at University Hospital of South Manchester. But I also have some national roles. I run the National Cardiac Surgery Audit, which has been publishing results at organisational and individual surgeon level now for some 10 years or so. And I'm also responsible through the Healthcare Quality Improvement Partnership for managing the programme to publish results across 12 surgical specialties and interventional cardiology. The NHS is moving from measuring process things to measuring outcomes, and it's an easy thing to say, it's quite a difficult thing to do. We're now trying hard to measure the outcomes of various different things, particularly clinical outcomes. One of the things that has come out of both Bristol and mid-staffs is the need to be transparent about outcomes. So there's now an edict to publish results for individual doctors across some 12 specialties, 5,000 odd surgeons. And the idea is that if you actually publish those outcomes, that process on its own improves quality of care, but it also allows people to see where quality of care is not as good as it should be, and it forces organisations and people to take action to make those results better. Having been doing cardiac surgery all through this programme, you start to think pretty hard about, what do you need to do to get the best outcomes? And some of that is about providing the best quality care, and some of that's providing the safest quality care too. So whilst our stuff that's published is about your activity and your mortality rates, we realise that to get low mortality rates you need to do very high quality surgery, you need to have very high quality anaesthesia, great intensive care, really good perfusion, very well led wards, very well staffed wards. You need to have great non-clinical managers too. So you require the whole bits of the jigsaw, and it's getting those bits of the jigsaw right which gives you results. So whilst the results are published under my name, we're very cognizant it's the whole team and the whole organisation that needs to be right to get the best possible results. Transparency is a particularly important part of quality in my view, because the history of this, and it came through very clear from both mid-staffs and Bristol, and from other things such as the breast surgeon Ian Patterson in the Midlands, is that quite often there are problems in the system. Quite a lot of people know about those problems, but nobody does the right thing to sort those out. I think that's changing. I think the NHS is a very different place to what it was a few years ago. But actually, by putting transparency out there and putting these results out there, it does make people know exactly where they're at. People can make choices, the public can make choices about where to go, but I think that's a smaller part of the effect that you get from transparency. I think the biggest part of the effect is keeps people honest, keeps organisations honest. They know if the results are not as they should be, they need to do something about it, and they can't brush under the carpet. In general, when you ask patients, they welcome outcomes to be available. I think that enables them to make choice if that's what they want to do, but it also gives them reassurance that the quality of care is good, and it also gives them reassurance that the quality of care is being monitored. I think quite a lot of people in the profession and quite a lot of people in the NHS find that quite challenging, but it's certainly what the patients want. It's their outcomes, of course, not our outcomes. And I think what's required is a significant cultural change for all working in the NHS to see things much clearer from the patient's perspective. And that includes publishing clinical outcomes, but it also improves publishing patient experience data as well. We've got stuff around the friends and family test, but I'm not sure that's necessarily good enough yet, because I think the patients will be often the first people to tell you if the organisation's not as safe as it needs to be. In my view, being a non-executive director of an NHS trust is an enormously challenging job. You have huge responsibilities, and they're very complex organisations. You need to be cited on issues of quality, but it's quite hard to do that. But I think the job of the board is to be asking the right questions, to seek out assurance that quality is generally as good as it needs to be. And that's not reassurance, that's absolute assurance. They need to see the data. That data needs to be presented in a coherent way, repeatedly. They need to know the areas in their organisation where things are strong. They need to know areas where they're not so strong and ensure the right things are in place to deal with that. And I think they also need to understand the prevailing culture within NHS, because for me that's like a supertanker, and it has been going in the wrong direction, and I think it's starting to change round. There's various tugs which are nudging it in the way it needs to go, but I think it's important all boards realise some of the challenges that their clinical leaders have to get truly high quality patient focused care delivered in every department in their hospital.